Hello, everybody. I'm Dr. Eman Aljufairi. I'm a consultant histopathologist in Bahrain. I work at King Hamad University Hospital. I'm interested in lymphoma, and so that's why this lecture I'm giving is about the update of lymphoma classification by the WHO. So we start with a bit of a history. So the classification of lymphoma went through multiple changes over the last century. So like one of the first classification was the Rappaport classification in 1965. And at that time, because we didn't have any immunohistochemistry, the whole classification was based solely on morphology. So they were like dividing it, is it a diffuse architecture or nodular? And then by morphology, do they think these cells are lymphocytes, histiocytes, or undifferentiated? As we discovered immunohistochemistry later on, new classifications came. So in the US, the Lukes and Collin classification came where using the immunohistochemistry, they divided lymphoma into B and T cell lymphomas. At the same time, the Kiel classification happened in Europe, and they added along with B and T cell subclassification, whether it's low or high grade based on morphological features. Kiel classification was more of a success in Europe, while Lukes and Collin classification was not so much accepted in the US. And that's why in the 1982, the National Cancer Institute tried to do the working formulation classification. And they were like stratifying lymphomas as low, high grade, intermediate based on the clinical outcome. But they didn't include the immunohistochemistry in their classification. And that's why it needs more workup. So in 1994, we have the revised European American lymphoma classification, where we had a consensus sort of hematopathologist experts. And in this one, we sort of went into the new era where we're looking at morphology, immuno-phenotype, genetics, as well as clinical features to define each entity. After that, the first worldwide consensus came in 2001 as the WHO classification, or what we usually refer to as the blue box. So the third edition came in 2001. In 2008, we had the fourth edition. The updated fourth edition came in 2016, and the latest edition, the fifth edition, came last year. Okay. There were lots of changes in the fifth edition, so I won't be covering all of them. I'll be covering the ones I'm listing here. So I'll start with some low-grade B-cell lymphomas. So I'll be talking about lymphoplasmacytic lymphoma subtypes and how is the change from grading to grouping in follicular lymphoma. Then we go to the high-grade B-cell lymphomas. We redefine double-hit lymphoma, introduce some new sort of terminology by calling high-grade B-cell lymphoma with 11q aberrations and primary large B-cell lymphoma of immune privileged site. Then I will go for T-cell lymphoma, talking about the Alk-Negative anaplastic lymphoma, as well as the peripheral T-cell lymphoma in OS. So we start with lymphoplasmacytic lymphoma. So as it's known to all, lymphoplasmacytic lymphoma usually have a heterogeneous group. So you usually see small B lymphocytes, plasmacytoid lymphocytes, as well as plasma cells. It's mostly involved the bone marrow, but it also involved extranodal sites and lymph nodes. When it comes with hypergammaglobulinemia of IgM, that's what we call Waldenstrom macroglobulinemia. And the new change that in the new WHO, we're making a distinction based on the serum monoclonal immunoglobulin. So if it's an IgM, that will be your IgM lymphoplasmacytic lymphoma or Waldenstrom macroglobulinemia. While for the other subtypes, we will have the non-IgM LBL Waldenstrom macroglobulinemia. And I will go a little bit in details about. So the IgM, that's the most common subtypes, and that's what we usually know. And as we say, it's usually infiltrating the bone marrow, and actually it's sort of an essential for diagnosis now in this subcategory. So even if the LBL is producing IgM, if it's not infiltrating the bone marrow, we cannot put it in this category. And most of these patients will have the MYD88 mutation, which was like a game changer, like since the last classification for defining LBL and making it apart from the mimickers, especially marginal zone lymphoma, when we are finding it in the nodal and extranodal sites. IgM subtype usually will comes also with hyperviscosity syndrome because of the increased IgM in the serum. And many of the cases will also have the CXCR4 mutation along with the MED88 mutation. And the reason why now we are interested in this, in testing for this mutation, is because patients who have this mutation will not respond to the ibrutinib therapy, which is a tyrosine kinase inhibitor. So now, if anybody is going to be treated, you have to search for the mutation to understand whether they will be responders or resistant to tyrosine kinase inhibitors. On the other hand, the non-IgM LBL is rare, so it's only around like 5% of the cases, and that's when we have monoclonal IgG or IgA, and most of the time it's IgG. Rare cases will be non-secretory, so we don't have any immunoglobulins, and also it will include IgM LBL if the bone marrow is not involved. So as we said previously, for an IgM LBL subtype now in the new category, the bone marrow involvement is a must. So if you don't have a bone marrow involvement, it automatically comes in the non-IgM LBL. These are less likely to have hyperviscosity syndrome, and some of them, except of course for the IgM ones, can have bone marrow involvement, but it's less frequent. They are more likely to involve lymph nodes, spleen, and other extranodal sites. And they still also have the MED88 mutation, but to a less frequency. Some studies say that they have worse outcome compared to IgM-LBL. Other studies didn't confirm that. And the problem, I think, it's because it's very small group of cases. Because as we said, this is only 5%, and maybe now with this sort of the new classification and separating the two, we will be getting more data in the future to decide whether there is an actual difference in the outcome or not. Also, the time of treatment is usually shorter because, as we know, like usually for most of low-grade B-cell lymphomas, the treatment is only if the patient is symptomatic or have a high burden of disease that's affecting vital organs. Otherwise, usually it's an observation and waiting. So the non-IgM LBL more likely to need treatment after diagnosis in a shorter period. That's all about LBL, and then we go for follicular lymphoma. So follicular lymphoma is a very sort of well-defined entity. We know it for years now. And it's usually, we're talking about germinal center B cells. And we always refer to them as the small cleaved centrocytes and the large non-cleaved centroblast. And for all these years, we used to grade them from 1 to 3 based on how many centroblasts we have. So as we know, if it's less than 5, that's your grade 1, 6 to 15, that's your grade 2, more than 15, that's your grade 3A. However, in the new classification, the 5th edition of the WHO grading is no longer required, and we sort of divided follicular lymphoma into 4 subgroups. So we have the classic follicular lymphoma with unusual cytological features, follicular lymphoma with a predominantly diffuse growth pattern, follicular large B-cell lymphoma. So the classic follicular lymphoma is more or less what we've been knowing for years and what we usually call as follicular lymphoma. So it's the most common subtype out of the 4. It will, like in this new definition, it must have a follicular pattern at least focally. And as we all know, usually the follicles in a follicular lymphoma, they will be crowded, they will lack well-defined mantle zone, so it might be ill-defined or totally absent. We don't have any polarization or tangible body macrophages within the germinal centers, so that's what tell it apart from a reactive germinal center. So before we were doing gradings, as I said, 1, 2, and 3, but now, according to the WHO, we don't need to do that. And the reason is, first, we're bad at grading, like, because it's not so easy to identify centroblast, although like we describe it as large, non-cleaved, but then we have the cells which are intermediate, should we call them centrocytes or centroblast? We have also the follicular dendritic cells that might mimic a centroblast, and plus also we have different sizes of high magnification field. So trying to count them, like people tend to disagree, and we had lots of non-reproducibility, as well as that in the clinical setting, usually grade 1, 2, 3A more or less behave the same way. We already sort of took that step one step before in the last classification, because in the updated 4th classification, we were calling grade 1 and grade 2 together as low grade, and then we were only separating the 3A and 3B. 3B is no longer existing, as we will be seeing, because we gave it a new name. And now we're saying it's okay. Also, you don't need to distinguish between 1, 2, or 3A. You can still do it if your clinicians want it, if you are a morphologist, and because this is something new, maybe we'll get back to grading later on with more data. But for the time being, because of the lack of reproducibility and no significant difference in the outcome, the WHO doesn't need you to grade follicular lymphoma anymore, and we will just be calling this classic follicular lymphoma. Follicular lymphoma with unusual cytological features, that means it based on this kind of the cells you're seeing. So we said before that follicular lymphoma is usually your cleaved, small-sized centrocytes with a little bit of sprinkle of centroblast that increase with higher grades. In few cases, which is usually rare, the cells will be more of medium size. The chromatin might be immature or blastoid. So if you look at it on the H&E, you feel like you start thinking, could this be an ALL? Or in other cases, you have what we call large centrocytes. And what we mean by that is that the lymphocyte is larger in size, but still it's cleaved, it's irregular nuclei, it doesn't have a nucleoli, so this is not a centroblast. So these kinds of unusual cytological features, we're now putting them in a separate group, and we're calling it follicular lymphoma with unusual cytological features. These cases usually have high Ki67 proliferation rate. They express MUM1 by immunohistochemistry, and because of those two features, as well as the cells being larger in size than regular follicular lymphoma, whenever you're making this diagnosis, first you need to rule out the close mimicker, which is the large B-cell lymphoma with IRF4 rearrangement, by doing the FISH for rearrangement. That's the only way to sort of differentiate the two, especially if you're dealing with a localized disease affecting the head and neck region. We have only few cases, and this is sort of a new category, so we're not sure yet if there will be a different prognosis or worse prognosis as it seems. Maybe like now, as it's a separate group, as more data is accumulated in the future, we will know whether this will have a different behavior from classic follicular lymphoma, or it's the same, it's just the morphology is different. Then we have follicular lymphoma with a predominantly diffuse growth pattern. This is what we were before saying, like we usually, when we're talking about follicular lymphoma, we're dividing it, is it a follicular pattern or diffuse pattern? So now we're sort of giving it a separate name. So whenever it's predominantly diffuse growth pattern, that's when you don't see any follicular dendritic cells, even when you do immunohistochemistry for CD21 and CD23, still you don't see anything. then that's your diffuse growth pattern. So it's not just by H&E, because sometimes on H&E, you might feel this is a diffuse pattern, but when you do the IHC, you see that there is some areas of nodularity. These will be mainly centrocytes, so you have your small cleaved cells. And BCL2 IHC is usually weak or absent. They are more frequently to happen in guinar region, and they have STAT6 mutation in many instances. Because any follicular lymphoma will have a part of it which is diffuse, especially in the interfollicular areas, you can't make this diagnosis in a small biopsy. You need an excisional biopsy to make sure that there is no follicular pattern at all to give it this group. And then the last one is follicular large B-cell lymphoma. So this is what we used to call before as follicular lymphoma grade 3B. And that means you still have the follicular pattern by H&E or by IHC when you do the follicular dendritic cells meshwork markers. But these follicles are only composed of large cells, which are the centroblast. It's rare for follicular large B-cell lymphoma to be pure. So most of the time it's coexisting with diffuse large B-cell lymphoma. And that's why you need to have more sampling. And if it's just a biopsy, you might want to ask your clinician to go for an excision just to rule out there is no coexisting diffuse large B-cell lymphoma. Rarely, it can be also associated with sort of classic follicular lymphoma, which means low grade, but that's rare. And then again, because this is large cells and MUM1 sometimes can be positive by IHC, again, we will have to rule out the large B-cell lymphoma with IRF4 rearrangement by doing FISH studies. So as you see now, we've always had problem about how accurate is grading of follicular lymphoma on small samples, whether we're talking about fine needle or core biopsies. Now with this new classification, it's even more problems. So if we want to do an accurate subtyping and grouping, we need an excisional biopsy for primary diagnosis. Biopsy and FNA is not the best unless excision is not feasible. And in those, you will have to write a comment that you're doing this based. And as I said, like, especially if you're seeing diffuse pattern, it will be difficult to ascertain which grouping you're talking about. So you can give it just as a follicular lymphoma with a comment that because this is a limited material, subtyping or grouping cannot be done. Okay, we jump now to the high grade. So double hit lymphoma is a sort of an concept that's been evolving over the years. So in the initial 4th edition, we had this entity called B-cell lymphoma, unclassifiable, with features intermediate between DLBCL and Burkitt lymphoma. And this is basically was high-grade lymphomas that looked like Burkitt, but it's not totally fitting. Maybe the IHC is a little bit different. The morphology is a little bit more polymorphous than you want for Burkitt lymphoma, but it's not like your regular DLBCL. So this gray zone diagnosis was made in the 4th edition. As we came to the updated 4th edition, because we started to do more molecular and genetics on the DLBCL cases, we realized that many of these unclassifiable cases had double hit mutation involving MYC with BCL2 or BCL6, and some cases would have rearrangement of the 3 genes. So that's what we were used to call triple hit lymphoma. So the name became, like, for short, we usually call it double hit or triple hit lymphoma, but the actual name became high grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangement. In the 5th edition, we're sort of rechanging the name because we are removing the BCL6 rearrangement. So now it becomes diffuse large B-cell lymphoma / high-grade B-cell lymphoma with MYC and BCL2 rearrangement. And the reason why we added the part diffuse large B-cell lymphoma, because as people started to do FISH on all the cases of large B-cell lymphoma, they realized that many of double hit lymphomas will have a morphology that's no difference from a regular DLBCL. It's not just those cases which looks high grade or unclassifiable. Even a case that looks like routine DLBCL might have a double rearrangement. And we removed the BCL6 because they realized that the cases which has MYC and BCL6 alone without BCL2, they were a heterogeneous group. They have variable gene expression, variable outcome. And unlike the double hit lymphoma, which involved MYC and BCL2, they were more likely to be germinal subtype. They have worse outcome in general. These were more likely to be activated B cell-like on gene expression profiles. So the group of the WHO decided that this time we're removing the BCL6 rearrangement group, and it will go back, depending on its morphology, to either the wastebasket of DLBCL NOS or high-grade B-cell NOS, depending on the morphology. So DLBCL high-grade B-cell lymphoma with MYC and BCL2 rearrangement is an aggressive lymphoma, and it's a definition by molecular because the morphology is very variable. It can be Burkitt-like morphology. That means you will have your monotonous, medium-sized, atypical lymphocyte sheeting with starry sky appearance. But on IFC, it will not behave like Burkitt. So you will be having maybe more expression of BCL2, less than your 100% proliferation rate. And then if you do the gene rearrangement, you find the double hit MYC and BCL2. Some will have blastoid morphology, so they will have more similarity to acute lymphoblastic leukemia or lymphoma. And some might look just like a regular diffuse large B-cell lymphoma. So that's why the percentage of double hit lymphoma is differing in different countries based on their resources. In places like Europe and US, where they are doing FISH for every case of DLBCL, it's around 10% of the cases will be double hit lymphoma. In places where they are only going by morphology and doing it only when it looks like high grade, or if the patient has aggressive course or early recurrence, the percentage might be less. Many of these cases actually will also have BCL6 rearrangement, so that will be like sort of a triple hit lymphoma. And you can see here on the side one of the cases that I had, and it was positive for MYC and BCL2 rearrangement. So you have these sheets of large cells, you have frequent apoptosis and mitosis. For this case, the proliferation rate was very high, maybe like 80 or 90%. And then with FISH, we got the diagnosis of the DLBCL with MYC and BCL2 rearrangement. This usually happens in elderly, so the young people usually will not have the double hit lymphoma. The median age is 60. There is a slight male predominance, but it occurs frequently also in females. Most of them will come with advanced disease, so stage 4 disease, high LDH, and CNS involvement is very common. Many of them will not respond well to the R-CHOP or have an early relapse after an R-CHOP treatment. That's why some people will advocate for more aggressive therapy when it comes to double hit lymphoma. If the patient can't tolerate, they give them something more similar to Burkitt regimen. And then we have another entity, which is high-grade B-cell lymphoma with 11q aberration. This is another entity which is based entirely on molecular. You can't make the diagnosis without the molecular investigations. In the previous WHO classification, it was called Burkitt-like lymphoma with 11q aberration. The change in wording is because on a molecular level, we discovered that these have more genetic aberrations similar to DLBCL rather than Burkitt. So because it became more of a misnomer, that's why Burkitt-like was removed, and now it's high-grade B-cell lymphoma with 11q aberration. However, when you look at it under the H&E, it will look like Burkitt. So the morphology is the medium-sized atypical lymphocyte sheeting with lots of changeable body macrophages, starry sky appearance. You do your CD20 and it's strongly and diffusely positive. BCL6, CD10, your germinal cell markers are positive. Your Ki67 is very high, which is almost 100%. The only difference it will have is like if you send it to FISH to look for the MYC rearrangement, the MYC rearrangement is not there. And instead of that, they have this alteration at the 11QR, where it's either a gain or a telomere loss. And they will also have more complex karyotype in comparison to Burkitt, which is usually a simple karyotype. And as we said, so it's more close to germinal subtype of DLBCL, but the behavior clinically is more aggressive and it's similar to the Burkitt. So many people still are treating it like Burkitt when it comes to chemotherapy, but that might change in the future if we find something more specific for it. Okay, this is also another name in the new WHO, and it's called primary large B-cell lymphoma of immune privileged site. So any large B-cell lymphoma that's primary of central nervous system, vitreoretina, or testis will go under this. So it's like incompensates sort of 3 subtypes we know previously in one, and the reason why it became one group is because all of them have the same sort of characteristics. They are arising in an immune centuries because of the sort of anatomical barrier. So in the CNS, you have the blood-brain barrier, you have the blood-retina barrier. For testis, you again have the testicular blood barrier. So lymphocytes and everything doesn't have easy access to these sites, and that's why sort of they are unique from the regular nodal or extranodal lymphomas. And to make this diagnosis, you need to rule out any secondary involvement by systemic DLBCL. So it has to be a primary of those sites. And then there should be no history of immunodeficiency or dysregulation. They share similar morphology, similar immunophenotype. So of course, by morphology, these are large B cells in diffuse sheets. And one example here in the picture is from the testis. You can see the sheets of large lymphocytes and with the entrapped seminiferous tubules. When it comes to immunophenotype, they usually have post-germinal center B-cell phenotype. So beside your B-cell markers, they will be positive for MUM1 and BCL6, while CD10 usually will be negative. In rare cases, CD10 can be positive, but in those cases, you need first to rule out it's not a secondary involvement, because as we said, that's rare. And then they are usually also not related to EBV virus. But so whenever you have an EBV related lymphoma in these sites, the first thing is you need to rule out that this is not something related to immune deficiency or dysregulation. Then that will go into a different subcategory. Many of them will have the MYD88 or CD79 mutations. And as this a new group, it might be expanding in the coming years. Maybe it will also include primary lymphomas of the ovary, breast, and maybe even the skin, because these are usually also behave differently from the usual systemic or extranodal lymphomas and have a sort of more similarity to these groups. But for the time being, it's what's included is only the CNS, the vitreoretina, and the testis. We shift gear to the T cell lymphocytes. So we have anaplastic large cell lymphoma, and it's usually divided into either ALK positive or ALK negative. ALK positive was always the better prognosis. It's more in kids. It's better outcome, while the ALK negative is usually more in adults, and it has a worse outcome. And by definition, it's a mature T cell lymphoma, so you will have to express the T cell markers, CD3, CD5, although many times they might be lost and only very few T cell markers will be positive. So the most usually is CD43. And then the main thing is they have to be large cells. They have to express CD33 strongly and uniformly. That's what distinguishes it from a peripheral T cell lymphoma. So if you have large atypical lymphocytes, which are T by immunohistochemistry, and then CD30 is uniformly and strongly expressed, that will take you to the ALK-negative anaplastic large cell lymphoma. And of course, by definition, you should not have ALK expression by immunohistochemistry, or if you're doing molecular, you will not find ALK rearrangement. This was a heterogeneous group, and at some point, people were questioning, should it be a specific entity? Should it be along with peripheral T cell lymphoma in OS? But the gene expression profile studies confirm that, yes, it's a heterogeneous entity, but it has more similarity with the molecular signature of ALK positive anaplastic large cell lymphoma. And that's why this sort of stayed in the definition. As we started also doing more molecular and genetic testing, we started to find some recurring rearrangements in this group. So these are the most common, like the DUSP22. And initially it was said that cases which has DUSP22 will have a better outcome, which is more similar to ALK positive rather than ALK negative. However, as we started to see more and more cases, some of them are now not behaving as good as we thought initially. So it's like now it's a question mark whether it's always better outcome or maybe it's somewhere in intermediate. Cases which have rearrangement of P63 or loss of P53 will have poor outcome. Because this is something like evolving, we're not sure, is this more of prognostic markers? So like, for example, when we say, you know, when we have high proliferation rate in a lymphoma, that's a poor prognostic marker. So is it something similar, but from a genetic point of view, or these are sort of molecular distinct subtypes and we need to sort of divide them? That's what we are working on, and we need more data gathering before we decide to split this entity into 3 groups. Okay, now we talk about peripheral T cell lymphoma in OS. So again, that's a heterogeneous group, and it's usually poor outcome. T cell lymphoma overall is rare compared to B cell lymphoma. So we have lots of non-reproducibility when it comes to the diagnosis because of less seeing it. And it's recently we started to see that we can also divide them into groups based on molecular classification, similar to what happened to DLBCL like a couple of decades ago. So the T cell lymphoma, when we did the gene expression profile, we found that there are 2 groups. One that's we're calling the GATA3 group and the TPX21 group. And you can see for the median overall survival, the GATA3 will do worse, while the TPX21 will do better. So this sort of made a new definition of like sort of we're trying to make more unified groups, better prediction of the outcome. However, because this is gene expression profile, it's not easily available. Most people will not have access to it. People started doing what we tried to do with DLBCL and the germ cell of origin thing. that how can we do this with IHC, because IHC is more ready available. It's easier to control and you don't need a fresh tissue. You can do it on the regular paraffin embedded tissue. So this is the algorithm that the group came with. So you need 4 IHC markers, GATA3, CCR4, TPX21, and CXCR3. So first we start with the TPX21 IHC. If it's more than 20% of the atypical lymphocytes are positive, then that's TPX21 subgroup. If it's less than 20%, then we go for CXCR3. Again, the cutoff is 20%. If it's positive, then again, it's TPX21 subgroup. If it's negative, then we do the GATA3. So if GATA3 is more than 50%, then it becomes GATA3 subtype. If it's less than 50%, we do the CCR4 IHC. If it's more than 50%, then that's GATA3 subtype. If it's less than 50% after these, so that's mean we're making it unclassifiable after doing the 4 IHC. And the study showed that this sort of works, and we still see the difference in outcome, similar to what we say when we have the gene expression profile data, and it has a good correlation, around 80 to 90% correlation with gene expression subtyping. A little bit more about each subgroup. So from the name, the BTCL GATA3, that's when you have more expression of GATA3 and all the target genes that it targets, including the CCR4 that we used it in immunohistochemistry classification. These usually are T helper type 2 cell differentiation. They will regulate lots of cytokines, and they usually have lots of genomic aberrations, deletion of multiple tumor suppressor genes, including the P53 and the P10. They have a lot of MYC gain and amplification, and sort of looking at all this genetic, no wonder that these cases will behave worse, because they have lots of complex genomic, they have sort of autonomous growth, especially with MYC gene amplification and the deletion of P53. On morphological level, these are usually the monotonous T-cell lymphomas. So they are either intermediate or large in size, but it's monotonous. You don't see any mixed inflammatory background as you see in the picture. So more or less, you just see sheets and sheets of either medium or large atypical lymphocytes. You don't see much of inflammatory background. And most of them, they will behave like T follicular helper cells. So they are CD4 positive, CD8 negative, and they don't have cytotoxic markers. While the other group, the TPX21, again, from the name, they will have high TPX21 and its target genes, and that's what we used in the immunohistochemistry. These are mostly cytotoxic T cell or T follicular helper type 1. They regulate the interferon gamma, and they go by the N-kappa beta activation. They have less genomic abnormalities. They are more of epigenetic regulator mutations, and that's might say why they are sort of less aggressive. And on morphology, they are polymorphous. You have lots of inflammatory background along with it. So this, and so pattern 3, and when you have mixed inflammatory background, and also the neoplastic cells, they are variable in size, they are not monotonous. And then pattern 4, or like the other type, is what we used to call, based on the morphology, the Lennart lymphoma pattern. That's mean where you have lots of histiocytes and mixing with the atypical lymphocyte, and sometimes they even might mask the atypical lymphocytes. Their IHC is heterogeneous. They can be CD4 or CD8 positive, and they usually express cytotoxic markers because they have cytotoxic differentiation. That's all for me. Thank you, and have a nice day.